So I'd like to begin by acknowledging the traditional owners of the lands of which we're meeting today and recognise that these lands have always been places of teaching and research and learning, and pay my respects to elders past, present and future. Thank you so much for joining us for Tea and Buns, everybody, and for those watching the recording as well. Thank you for joining us and listening into this very important conversation, because as you know, Tea and Buns is always about sort of thinking about topical issues that are going on in the community. We like to talk to, you know, thought leaders, researchers. We like to talk to people who can inform us, but also give us some really helpful tips about things that they have been researching or thinking about. And today over the last couple of months, really, I've been trying to think about this month's session, and what we're all talking about is this COVID vaccine, and it's really heated up in the last few months. So today seemed very pertinent that we invite someone to come along and talk about the vaccine. So I wanted to just frame this conversation right up and say, this isn't a conversation about whether you should or shouldn't have the vaccine. We all have our own opinions, but this was really about giving you some information about how to deal with conversations that might be going on in your organisation. That's either with staff and your own colleagues or with people that you're working with, because that is a very big challenge for us all in the non-profit sector, where we have clients and we have service users, and we really need to be able to have positive and empowering conversations around a very difficult and challenging topic right now. So on the screen now is just a reminder that we are going to use very respectful language today. We're going to obviously have our own opinions. That's totally fine. We're okay with that. But we're going to keep this conversation really respectful. And Tash will, if there is anything that comes up that she feels would be better for you to go and speak to your own GP about, or a lawyer possibly, Tash is very open and honest, and we'll just say, look, that's a conversation that you need to have with XYZ. So Tash is coming along to have a conversation with us. I have got a heap of questions for her, but you are also most welcome to ask some questions as well. We do really want to know what you'd like to find out, and so you can use the chat if you want to pop some a question in the chat, and I'm going to try and keep an eye on the chat box there. But if you want to come and just unmute as well, that's totally fine. It's lovely to see your faces, absolutely brilliant, but that's okay if you haven't got your camera on. We just know that you're there, so feel free to use the chat as well. All right, so that's our little agreement for today. I wanted to start off really with having a little bit of research, because you know that ACP&S, we all love a bit of research. And I saw that there was a very interesting report done by McKinsey. They were asked, obviously, or they took this question out to the US consumers, and they said, when the pandemic is over, what do you want to splurge or treat yourself on? So I thought we'd just kick off with a bit of fun this morning and just put in the chat, when you think the pandemic is over, which the COVID may or may not help, the vaccine may or may not help with that. What are you going to splurge on? Let's see if you say the same things as the results of the McKinsey report. Okay, travel, yes. I'm so desperate for some travel. Oh, we've got lots of travel happening. What are you going to splurge or treat yourself to? Let's see if you want the same thing as the US consumers. Oh, everybody wants to travel, don't they? Yeah, totally. We're not even going to get to New South Wales. I had to cancel my Melbourne trip the other day, just a couple of weeks ago, which was so sad. So if we can't even get around Australia, we really want to go and see family and friends overseas. And of course, my family's in England, and I haven't seen my family for a long time now, which is really, it's one of the things I want to do. All right, cool. We've got a lot of travel. Anything else? Let's see. I'll share with you what the McKinsey report found. I think it's all a lot of family and visiting friends, that experiential things that we want. All right, let's have a look at the McKinsey report then and see what they found. Well, so this was a survey done, and I just thought I'd show you, it was about 2,000 people that answered this question. So they kind of weighted it to the US general population. And more than 50% said they expect to spend extra by splurging and treating themselves. So they all agreed, yes, as soon as we feel this pandemic is over, we are going to treat ourselves. And around half of them said that they are pandemic fatigued and intend to spend soon, particularly on fashion, beauty and electronics. Isn't it funny how we just feel like when we've been constrained, or, you know, when we feel that we haven't been able to get out and spend, we really want to do this, you know, on pretty much anything, but lots of people love fashion and beauty and electronics. And the other half is waiting for the pandemic to fully resolve and want to do more things like going and eating out and travel, which most of you have said that you'd love to do as well. So I thought that that was just an interesting place to start this conversation, because when we think about the vaccine and we think about what's being talked about, many people are saying the vaccine is going to be, you know, it's going to be the answer, and, you know, the whole pandemic's going to be over when we're all vaccinated. It's one of those things that, you know, is being flouted in the news. Anyway, consumer optimism remains high. So let's hope that's true in the Australian population as well. So thanks everybody for joining us, and thank you Tash, Dr. Natasha Yates, and I'm going to call you Tash Yates, Tash, because I can't say the Natasha, it sounds a bit formal, so I'm going to call you Tash if that's okay. Tash is a practicing GP, and also though is an educator at Bond University, working with up and coming GPs and doctors, and also really works around how to support doctors to think about their patients and how they make informed decisions and critical thinking. So Tash, I know I've been following what you've been sharing with the community, Tash, because you really haven't just been sort of keeping to the university or even your own practice. You've really been talking on the radio, sharing with the conversation. You've really been using your abilities and strengths to share with the community what you think about the pandemic right from the start. So I know that you are a real honest and authentic voice in this conversation, which is why it made total sense to invite you today. So thank you so much for coming. And I will just like to say that Tash is also an author, and she has 4 children, 4 beautiful children. And so she also has to speak in plain and simple language to the children, and it resulted in a children's book. So if you want to check out Rhina's story, it's a beautiful book, which my children have read and loved, and it's all raising money for work in Mozambique. So thank you, Tash, for your, you know, compassion for the community, your love for, you know, helping people make informed decisions. Thanks for coming along today. And I really wanted to just start off by asking you, you know, you have been this practicing GP and working with schools and the community this whole time. What is the most frequent question that you've been asked?
Well, that's actually changed over time. I guess this time last year, we were just emerging from lockdown and people just kept on asking, well, is it over? You know, what's going to happen from now on? And then Melbourne outbreak happened. So, you know, back then the question was, you know, are we going to be able to go back to normal life? I think now people have realized normal is not going to be what it used to be. We're going to have to develop a new normal. At the moment, probably the most frequent questions I get asked around COVID are around the vaccine. So this time last year, I think we would have been, if we'd known that there were several really strong vaccine candidates that were going to be available within 12 months. Well, most of us would have been delighted. I think the way that things have been rolled out have left a lot more people uncertain and doubting. So most of my conversations in COVID now are around specific questions about the vaccine and really about, will this enable us to go back to normal as a community?
Yeah, big questions. All right. Well, that's certainly questions that have been on my mind as well. And I think that I wanted to frame today's conversation in four sort of areas, but I'm totally open to everybody online today and what you'd like to ask Tash. So we're going to talk, I've got a heap of questions here for you, Tash, and we're going to start with informed consent, just giving us a little bit of a scope around, well, what is informed consent? Then we'll move on to the actual vaccine then and get some information from you about what this means. And then we'll talk about our role, or the role of different people in the community, and especially if we are in a if we're talking with colleagues or we're talking with service users, what is our role? And then I really wanted to land it somewhere really interesting, is opposing views. What happens when people have different views to us, and how can we still encourage a positive and empowering conversation when people do have different views? So that's my kind of outline for the next few minutes, and I'm going to keep an eye on the time, and I'm definitely going to keep an eye on the chat box. So again, if anybody wants to join the conversation, ask Tash anything, please put it in the chat, and let's see where we go. So thanks, Tash. All right. So my first question then is around informed consent. So many of us will have heard those words, informed consent. But can you give us a little bit of an understanding of what does that actually mean to have informed consent?
Yeah, sure. And this is something that's just very relevant, not just to vaccines, but to anything within my field. So anytime we're starting someone on a medication or talking about an operation being done, or even talking through the options for those, whether they decide not to have it, it's so important that there are 4 criteria that are met. The first is that person actually has capacity. And I realize some of you might be working in fields where you're working with people who don't have capacity. So what capacity is, sometimes it's the other word that's used as competence. Are they actually able to make a decision? So I guess an extreme example would be, let's say someone's in a coma and they maybe if they woke up, they'd be able to make a decision, but right now they don't have that capacity to do that. But for some people, they're in a more permanently incapacitated situation. And in those situations, someone else needs to step in. So there's surrogate decision makers that can be appointed. I guess for those of you listening, it's not up to you. It's not on your shoulders to decide if someone has capacity or not. If there are any kind of grey zones, if you're talking with somebody and you think maybe they're intellectually impaired or unable to make a decision, that's something that you need to take them to a professional, take them to a doctor to be able to determine that. That's not on your shoulders. And if you've got any doubts, it's just better safe than sorry to make sure that they're not being asked to make a decision when they physically are not able to. So capacity is one point. Second thing is information. Actually, to make a decision, any of us need enough information. We need to know the pros and cons of choosing something. The third thing we need is comprehension, so understanding of that information. It's not good enough. So for example, if someone doesn't speak English as their first language, just giving them information, whether written or verbal, is sometimes not sufficient. We need to actually make sure that they've understood that information. And then fourthly, and this is super important, is that consent or decision not to go ahead needs to be voluntarily granted. So there needs to be no coercion from anyone, not from health professionals, not from their family, not from someone who has secondary gain in them taking that decision. So legally and medically, those are the kind of the 4 conditions. So if somebody has capacity, they've been told all the information, they've understood all the information, and then they make a decision without coercion, that's considered an informed decision.
So even GPs and medical people are not allowed to coerce you into making a decision.
Absolutely, yeah.
Yeah, that's great. So are there some principles from a community perspective then? I mean, we're not doctors, I don't think anybody else is a doctor, a medical practitioner. So what could we remember then from a colleague, or maybe we're talking to our family, what could we remember as principles around informed consent? Is there something really easy that we could remember?
Yeah, so I think it's very much about making sure when you're having conversations with people that they are understanding what's being explained to them. And then if they are interested in a topic, that they have full access as much as possible to all the information that they need. Too many of us since COVID particularly have ended up in echo chambers and only hearing little snippets of information, not being able to put it together. And I think that's where people like us are able to maybe have a bit of a better capacity to explore a variety of perspectives, maybe to bring different kind of information sources to people who've really been narrowed down. And then just so important, this coercion I think is so important. Too often people might be coerced, not, it's obviously if they're being coerced by being threatened, but sometimes coercion is more an emotional or mental manipulation. And I feel very strongly, I'll admit I am pro-vaccine. I do think vaccinations are important in our community. I'm not in the pay of the drug companies, I can promise you that. If I am, I'm yet to see any check. But I do think vaccines have a role, but I don't think that they are the kind of the magic one that's going to turn everything around and take us back to pre-COVID days. I think there are pros and there are cons. And with coercion, I never want to manipulate my patients into making a decision for a vaccine. If somebody decides to have a vaccine or anything else, I think they need to have done that without any, not feeling that they're going to let people down if they don't make that decision.
Yeah. And I think you touched on something around all these information sources, is that, today with social media and the internet and Mr. Google, who knows everything, we just have so many different opinions, don't we? And we have so many sources of information that are being thrown at us. And it's really hard to kind of, work out what we should be reading or what we should be listening to. Or as you say, sometimes when we read one piece of thing, it can be very persuasive for or against. And, trying to work through all of those sources of information and who is telling the truth and who's talking in our best interest and who isn't. It's very hard, isn't it? Do many patients come to you and say, I just can't work out what's the best decision to make?
Yeah, absolutely. And you're right. It's because there is too much information, and learning how to navigate quality of information is not something that our generation did. Maybe I'm showing my age there, but I didn't grow up with the internet. And so learning how to discern what is fake news, what is truthful, what is half-truths. Half-truths are actually the hardest to decide on, I think. It's difficult. And I think that's somewhere, again, that we can actually, it's hard work. I'm not going to pretend that this is something that I have any magic abilities in. Working at Bond Uni, we are very strong in evidence-based practice. And so I teach things like cognitive bias and I teach things like discerning quality of evidence. And I still struggle. I still sometimes have to really wrestle with some information before I get to the bottom of it. So I think that's something that we can do, and we can go on, I guess, if you're interested, I'll just tell you a couple of kind of life hacks that I use really just quickly. I guess the first thing is you just look at who it is who's making a claim. Do they have anything to gain from making that claim? Often people will point at big pharma and say, oh, well, the drug companies, of course, have secondary gain. And to a certain extent they do, because they are selling something, they're making money out of it. However, there are many, many people making counterclaims that also make their career is based on being an anti-vaxxer or being an anti-pharma. They get, it's a multi-million dollar, if not multi-billion dollar industry in and of itself. So just because somebody is pitching themselves as being the David in the David and Goliath scenario doesn't mean that they actually are. Sometimes they are actually the Goliath. Interesting facts is that I was doing some research for one of the articles that I was writing, and I discovered that vaccine companies, all the companies making vaccines, also all of them make vitamins. And in fact, their revenue from vitamins is in the order of magnitude of at least 10 times the amount that they make from vaccines. Wow. So if they really were interested just in making money, they'd abandon the vaccines and they would just produce vitamins. They would just tell everyone, hey, vitamin D, vitamin C, whatever vitamin is the one that's being touted at the moment, should be what you buy. And they'd make a lot more money, be a lot easier sell for them. But obviously they are also scientific institutions, so they're not doing that. So being armed with information like that and being prepared to dig a bit deeper is important. Apart from looking at who's making the claim and what do they have to gain from it. Another helpful thing I find is to do some fact checking, and literally you can get on Google. If someone says, makes a claim like, oh, they're collecting our DNA, just type in fact check collecting DNA from vaccine. Really simple, and you will find you don't have to do the hard work. Someone will have done a lot more research than you have capacity, time, training to be able to do. So I often find that those will present much more helpful information. Usually the fact-checking websites are balanced. I find that they don't just kind of push one perspective, they'll outline all the perspectives. And then of course, just finding your people that you find actually help you make sense of the world is important, but then being open to hearing other perspectives. All the way through the pandemic, even though I have put myself out there as somebody who writes about this, I have got people who still feel willing to send me things that don't support what I'm saying. And I really appreciate that. And I say to them, please keep sending me this because I want to wrestle with truth. I want to know truth. And if you just lock yourself down and say, I'm only going to listen to X, Y, Z, then you might miss out on information that could be helpful.
Thanks, Tash. Really good. And we have got a couple of questions coming through. Matt, did you want to have a chat and just ask your question? See if you can unmute.
I think it's
just unmuting there. Sorry about
that.
Yes,
that's it. That's good.
Just to go back, and this may have already been covered in what you've said, but I was wondering, in terms of the principle of coercion, I work in a environment. I'm at the Asylum Seeker Resource Centre, so we're a frontline service with a very, very vulnerable cohort of individuals. And we have been weighing up as we have all of our staff and our volunteers, frontline volunteers, have the right to be vaccinated. And we've been weighing up in terms of our messaging whether to encourage frontline workers in particular, but our staff and the volunteers to be vaccinated, encourage rather than mandate, because obviously that's a legislative nightmare. And that is mainly to protect our members who are extremely vulnerable and have limited access to medical services in this country, and there's all kinds of bastardry that goes along with that, as some of you may know. So it's an interesting space, and I'm wondering whether the coercion and what you're talking about is more an ethical category, or is it a legislative, a sort of a legal, or a category of potential litigation? If you can talk through that a little bit, because that's what we're trying to work through as an organisation. Encourage, not to encourage, get information out there. That was my first question. Sorry to be long-winded about it.
Oh, look, great question, Matt. And again, I'm coming from a healthcare provider perspective, so I guess you'd have to seek your legal team if you were looking at the legal ramifications. But my understanding of coercion is that you are not. For example, a way that would be coercion would be to say, look, if you don't get the vaccine, then I'm not going to keep treating you.
Right.
That, unless I feel that by someone not getting the vaccine, they're putting my life at risk or the life of my staff at risk, that would obviously be different, but I don't think that falls into this category. So in your situation, I think encouraging people is not coercing them at all. Coercion would be to say, right, everyone who's got the vaccine gets all of these benefits, and if you don't get the vaccine, yes, you can still work here, but we will make your life really, really hard. And whether that's overtly or covertly, there can be, I'm sure we've all worked in organisations where there's been bullying that's been flying under the radar. That kind of thing can happen in a kind of underhanded way, and that's why I say coercion can be emotional manipulation rather than a kind of obvious physical statement.
Okay.
I'm not sure if that helps. I do think when it comes to, particularly in your situation, you're dealing with very vulnerable people and possibly people who don't have English as their first language. Am I right?
Yeah. So to split it out, like we've had a couple of cases here just before the second lockdown in Melbourne, and obviously we had to shut down for 2 weeks. That had enormous ramifications for access to food, medical service, legal services, all of the things that we provide, to the point where people didn't have food on the table for a week. So in that circumstance, I'm talking more about staff and volunteers here that provide the services to members. We do have we have a vaccination program here for our members, for people seeking asylum. So it's about getting that balance right. If we can't mandate that volunteers and staff get vaccinated, but we do want to encourage them, because the consequences of an outbreak here, and members, if a member, and we have had that instance as well, if a member does get COVID, it's a dire situation in terms of access to the right medical services. I mean, there's a labyrinth in why that it can happen, but it's not simple. So it's look, what you've said already, I think, sort of answers it a little bit, that you can encourage whilst being mindful of the subtle forms that coercion can take. So positive encouragement, but just leaving it at that. Would that be kind of...
100%. And I think just also the second point in the 4 points of informed consent is the information. So the information you'll be discussing with your team about the consequences of not having it. So you've always got to think about the consequences of having a procedure, but the consequences of not having a procedure, and the consequences of them not having it. It's going to be a different conversation to, let's say, the kind of general public health message that will be given out to the general community, because obviously the risk-benefit ratio is quite different.
Yep.
So it is about that information sources, isn't it? Because when we have staff and volunteers who are, human beings, they're out on the community, they're looking at their own social media, maybe it's about really making sure as an organisation, what is it that you're giving people to look at and what you're encouraging people to look at. And again, not sort of going one way or the other, but saying this is what we want you to know about when you're making a decision about whether the vaccine is right for you, and helping them sort of find the right information to look at.
Yeah, the contextualization is important, because if they're just going to general kind of media sources, the risk-benefit ratios will be quite different to the risk-benefit ratios that will matter to your organisation, Matt.
Yeah.
And look, it's such a complex space, and disclaimer here, my partner is a virologist who works in vaccine development, so I have been living in the COVID cave for like the last 18 months. But it's such a complex thing, because when you say the risk benefit for the individual, that's a complex question in itself, because the epidemiological impacts of the numbers of vaccinations, it can't be reduced to a simple question of risk benefit for the individual, but that's a complex conversation itself, and that's precisely the situation we're in here. It's not about the risk benefit for the individual volunteer or staff member, it's about to our entire community that one person not being vaccinated poses. So it's not easy territory, but I think just some of the stuff that's been said now is quite helpful, actually, just gentle, positive encouragement, mindful of coercion. That's useful. Thank you.
And we do have to remember, Tash, don't we, that the vaccine is not the be-all end-all. Like, the reality is that we're still not certain exactly. It's looking positive in other countries, but we're not exactly sure what the vaccine is going to do, whether it's going to wipe it out completely or whether it is just one form of prevention or treatment. To try and lower the COVID risk.
Yeah, I think we can certainly say it's not going to eradicate COVID. I think everyone's now pretty certain on that. The question is, how much is it going to manage COVID so that it becomes another serious illness that we as a human race have to manage? Only one virus has ever been completely eradicated, and that's polio. Although smallpox. Polio came close, and then unfortunately they had an outbreak in Africa. But so when it comes to complete eradication, I think the general sense among scientists is it's not going away anytime soon, and it's really the vaccines. The role of the vaccines is one tool in the toolbox. along with all the other kind of things that we know about: social distancing, wearing masks, not maybe even lockdowns, but certainly kind of focused adherence to stricter rules when there are outbreaks. I think that's actually going to be part of our lives. Vaccines are going to make that a lot less intense and enable us to do things like travel, which we all want to do. But I don't think, if we think that, and this is where I'm quite passionate about correct information, people who are going out there and saying, everybody get vaccinated and then life will go back to normal. That's not truthful. That's just as untruthful as saying, don't get vaccinated because it's going to kill us. Both of those are extremes, and I think we need to give people informed decision-making options, which is, yes, vaccine is going to be very helpful for most people. Some people can't have the vaccines for a number of reasons. So those of us who can, even if our individual risk, and Matt's point there about the individual risk benefit ratio is actually quite difficult to calculate, because it very much depends on where you are at any given time. But as a community service to each other, getting vaccines done as quickly as possible is important. And I do vaccine clinics about fortnightly at the moment, and pretty much universally everyone who has come in for the vaccines has said to me, I'm doing this for my community. Which actually is wonderful, because it's been a nightmarish 18 months. And those clinics are some of the most uplifting times I have in my life at the moment, because it's the people who recognise their individual risk is very low at the moment, but they're doing it because they want to see the community benefit.
Meta has asked another very good question related to this, Tash, and she said, is saying that because the vaccine doesn't control all the strains, is that a reason not to be vaccinated? And maybe, is it saying, well, because it's not going to eradicate the COVID, I might as well just not bother?
Yeah.
Are you hearing that?
Look, not really. I'm hearing that there's some people who are very strongly anti-vaccine who will latch onto any criticism of the vaccine and use it as a reason to say we shouldn't get vaccinated. I mean, to me, that's silly. Just because it doesn't control everything doesn't mean it controls nothing. And so we need to do what we can do. It's like washing your hands doesn't stop you from getting sick all the time, but it stops you from getting sick most of the time, so you should still do it. And it is... On balance, I do believe that we should get vaccinated with what we've got at the moment. And we know that the companies that produce vaccines are working very hard to produce things that will be flexible and be able to target particular strains. The good news, though, just for where we are right now, and this could change over the next few weeks and months, but for where we are right now, even the more virulent strains at the moment, the Delta strain, for example, is still mostly protected by the vaccine, as in people who've had the vaccine are still mostly protected. It's just not as good as it was against the original strain, but it's better than nothing. And it's a good question, Nita, because I think if people are looking for reasons not to have the vaccine, I think this is one that is touted. And you've got to always think about, well, what's the question behind the question? And I think the fear behind that is that we'll go through all of this for nothing. But I can honestly say it's not for nothing. It just might not be for the kind of 90-something% efficacy that we had hoped it would be. But it's still in the 80s, which is still, to me, good enough. It's actually better than the influenza vaccine is right now.
So Tash, I mean, vaccines of themselves are not new. I mean, we know about vaccines. Many of us have been vaccinated for other things. And if we wanted to travel overseas, we've had to have vaccines, So what's the history of introducing new vaccines? Is this common that people have a lot of fear, a lot of, questions around new vaccines? It clearly isn't like, oh, yeah, we know what a vaccine is, so let's just get it done. Is this a common response, or is this different to the past?
It's pretty common if you read back through what happened when they introduced the smallpox vaccine, for example, and look at some of the cartoons of the day were quite telling. I mean, they were showing kind of the big mean doctor holding people down and jabbing them, and all the people petrified and not wanting to get vaccinated, were trying to run away and hide. And that's, I guess that's just a snapshot from 100 and something years ago, but we haven't reacted very differently as a human race, despite the fact that we've got a lot more evidence to show that vaccines are very effective and have saved millions, if not multi-millions of people's lives. So I think it's the new and the unknown. You're always going to get your early adopters. You're always then going to get the middle, a lot of people who, after they've watched what's happened, realize actually it's better than not. And then you will always get your people who, doesn't matter what the evidence shows, they are emotionally attached to not accepting it. And that's the way it is. Same with technology, very similar. If you look at what's happened with things like the iPhone, very similar kind of pattern of adoption.
And also skin cancer, and Louise is in the skin cancer world and knows that it's taken many, many, many years to encourage people to do slip, flop, slap, and that's taken a lot of campaigning. And, just because you don't have skin cancer right now, that doesn't mean you don't put sun cream on and wear a hat. So Louise, did you just want to ask your question?
Yeah, absolutely. And it's similar to that point too, Ruth, where we've had success in that area by going really upstream and looking at the barriers that are caused by other factors rather than just relying on individuals to act all of the time. And my question was around that as well. I mean, do we need to be looking much more upstream to not only encourage people or enable people to have the vaccine, but also to encourage them to have their second dose? And I say that because, in Queensland, they released eligibility for the 40 to 49 year age group a few weeks ago. And so that opened eligibility for me personally. And, I've worked in public health for a really long time, and I was shocked at how difficult it was to not only find how to register, but then this clunky process. I had to register, then I had to wait for an email back about my appointment, and I had to make my appointment, and I had to go to my appointment, which was fine. It was in a showground kind of thing, which was fine, a bit fun, I guess, in a way, to do that in a non-clinical environment. But then I've actually had to be really proactive to work out when to make my second appointment with no card that I took away on the day. So if I wasn't really on top of it, I could forget to make that second appointment. So I think there's some things that we can maybe do at that upstream level as well. And I was interested in your view on that.
Oh, Louise, 100%. I think it's safe to say that the vaccine rollout has been incredibly clunky, with many, many problems across the board. And, you're a highly educated woman who's highly motivated. Imagine what it's like for a lot of the people that we work with who are vulnerable and who are maybe not as convinced and who don't have computers or don't know how to navigate the systems that are out there. This has been a perpetual frustration for all of us who are working at the front line with trying to get the vaccines out there. And I think, I'm going to get on a hobby horse here, I think the big problem is that we've defunded public health.
Yes.
And then we've defunded preventative health, and our money has gone into the sexy stuff that you can show on the front page of newspapers because we saved this person's life with this expensive machinery, rather than putting it into paying for the on-the-ground workers at a primary and preventative health level. And we've been doing that for the last 20 years. So it's no surprise that you turn around and you get a pandemic where you actually need your public health workers to be, but they've got no resources, and now they're starting to have resources thrown at them, but you can't magically turn around on a dime and suddenly build an infrastructure to be able to do this. So look, I'm hearing you. To be honest, I'm kind of in just one cog in the wheel, so all I can do is comment on it. I've got some friends who work at a kind of higher policy level who are tearing their hair out because the people who get asked, the opinions that get asked on this kind of thing still tend to be your emergency doctors and your people within the hospital systems without any understanding that actually this needs to be done at a grassroots level. So I think the other thing that you might all understand this, but the health system in Australia is set up with both federal and state funding. And so general practices tend to be funded at a federal level, and much of the public health is as well. And hospitals tend to be funded at a state level, and they both have completely different processes, different people working in the systems. And when something like this happens, you kind of feel like mum and dad are fighting with each other. They never really talk to each other anyway. Now they've been told to come in and solve this crisis. They don't like each other. They don't want to have anything to do with each other. And we are caught in the middle as the kids. So I guess all I'm saying is that I 100% agree, lots of problems. I think what we can do on the ground, firstly, work out how to navigate ourselves, recognize how difficult it is, and then advocate, so that if we've worked out how to do something, then just try to get it out there through our resources, through our networks. This is where social media can be our friends. This is where, like a couple of days ago, I was phoned up by a journalist who had exactly your problem, Louise. Exactly your problem. And she said to me, Tash, is there something wrong with me? Have I missed something? Yeah. And I said, no, unfortunately not. And so we then did a news program on it over the radio. So that will have helped however many listeners there, but let's just use whatever networks we've got. But we need to keep on also speaking when we get a chance to the people who do have the potential and the power to and the authority to make some changes, because we can't keep going on like this. I think, it's been more than a year now. We need to get our act together and work out a more streamlined process.
So I think we're talking now really well about roles, and I did want to touch on that today, Tash, because we're friends, we're family, we're also professionals. And people like yourselves and Louise are public health, professionals as well. So what are the different roles? Do we have to sort of decide what our role is, or can we, can we decide what our role is? And Matt was talking about what is our role, for our staff and our volunteers. Like I just trying to get my head around this, I suppose, myself. And, should I shut up and not say anything, or should I be speaking about my views? Because I know that everybody's not going to agree with me,
Yeah, I mean, I've wrestled with this a lot as well, because I think with the problem with not speaking out is that there is a bit of a vacuum of information. And if we're not speaking, other people are. People are looking for information. And if we do have some information that we think would be helpful, I think we owe it to our community to share that. It is very contextual though, because it does depend. I'm just thinking Matt in his role, obviously what he says is going to be, what he says to his staff might be different to what he says to his family. And I think we have to think of the context and think of the listeners and think about how they might take what we say and how that might influence them. Because again, coming back to the coercion, we want to be careful to be sharing information, but not manipulating people into making decisions. If people had specific questions about that, I'd really, or if you've got comments, I'd love to hear about what it's like in your situations as well.
Matt's got a question. Go, Matt.
I was going to make a comment, just directly related to what you were just saying, Tash, about the about networks, because one of the things I experienced here, I mean, my staff team is only 5 people, but there's at the time COVID broke out, it was 1,300 volunteers here, and in the miasma of the media and social media universe of counter narratives and so much information, people, especially longer term volunteers, people who've been here 1, 3, 5 years, were really looking to us in lots of ways for guidance, whether we wanted to play that role or not. So playing that, taking that responsibility on board and steering people towards the right, my take on it was like, here's what DHHS says, I'll summarise it, here's what the WHO says, just go to those sources of information. Anything else, like, that's up to you, but these are what we're recommending and this is what we're basing our internal policies on. But it's in this, and as was referred to, the complexity of trying to book your vaccination and your second one. I just got my second dose of Pfizer yesterday, and the loops I had to go through in the internal system, and I understand how complex it has been to try and get this stuff set up. But then again, we've had 18 months to set up the systems, one of the richest countries in the world. So that's perplexing, and it's just that, it's just a comment about that role of not stewardship, but that when many people turn to you for at least a steer in a particular direction, there's a certain moral obligation and trying to remain as dispassionate and objective as possible. And I mean, my strategy has been, if people are really stressed, I'll talk to them, but just steering them towards one or two very trusted sources of information, and particularly the health directives of the day. So, I mean, I would be keen to hear what your view on that, or your experience on that, Tash, beyond just in practice as a GP.
Yeah, and look, 100% agree with you, Matt. So what happened with me was way back early in the COVID pandemic. I'm not on social media very much at all. Ruth will attest to this, that our kids go to the same school. The only reason I'm on it is because I wouldn't know what was happening at the school if it wasn't for Facebook, because the school's communication is via a website that I find unbelievably impossible to navigate. So that's the only reason I'm on Facebook. And then really crazy things were flying around. And I just started to answer my friends and say, hey, what about, I don't think that's true. Think about it from this perspective. And then the things that I was posting were going viral.
Yeah.
And I realized that there was a massive vacuum and in truthful, helpful, non-reactionary information. So I started to actually deliberately post information. And people found it so incredibly helpful. It made me scratch my head and thinking, I'm just saying to you what I say to my patients in my rooms. But it seems that social media is not set up to to amplify or share those kind of messages. And through that, then I started to, I was offered a regular radio spot. I write quite regularly now for The Conversation, that kind of thing. So I guess I've taken all of that. Each time I have thought very hard about it, nervously bit my fingers, talked to my husband about it, talked to friends about it, because I don't seek that kind of platform. However, as you say, Matt, if people are coming with those questions and if we're not speaking into that, they will be getting the information from elsewhere. And a lot of what I do, well, exclusively what I do actually, is look at reliable sources and try to then translate it into understandable language for the people that I'm speaking with. And it just so happens that people I speak with now tend to be a much broader audience than I do in my GP rooms. And I do think we've got that obligation, because if we're not, others are, and we owe it to our community.
So Tash, I really want to get in this question from Catherine, which is really where I wanted to also, go with this, is do you have people who come in and do or don't want the vaccine, which might be an opposing view to yourself? And what can we do when people are very having a different view? So whether it is or isn't about having the vaccine, how do we approach that and still maintain great relationships? Even in my own family, we've got different views on this. And so how do we maintain those good relationships with our staff, our family, our volunteers, our service users, when there is opposing views?
Yeah, really good question. So firstly, anti-vaccine sentiments are definitely not new. As a GP, that's been part of my kind of world for years. It's amplified now because the consequences for the whole community are so much greater from people who are very anti-vaccine. Most people who are not having vaccines at the moment are not specifically anti-vaccine. They're more along the lines of Catherine's question about not being able to choose the vaccine brand you prefer. It's more along those lines. It's people who say, look, I'm not anti-vaccine, but I don't want the Astra. It tends to be the flavour of the month, although a little while ago it was, I don't want the Pfizer. So we've kind of done a bit of a flip on that. And usually it's because of misunderstanding the kind of risk around that, so the individual risk around that. The Pfizer does have risks. I must make that very clear as well. It's not the kind of golden bullet. It's just because Astra's had so much bad press that a lot of people think Pfizer is now kind of the golden child, but both have risks. And so with conversations, however, the first thing to do with any conversation, and I'm sure you guys all know this, is just to listen, just to hear where people are at, find out what are their thoughts, where are they, where is their head right now, where is their heart right now, what is the emotion behind the decisions that they're making, or the kind of conflicts that they're having. So if someone comes in for a conversation, I assume that they've still got conflict and they've still got questions, and listen, and then try to get behind the questions. What is the fear? What is the uncertainty that is underlying? Because generally that it is fear and uncertainty that are driving people. And I, as a human being, want people to try to live out of a different paradigm. I'm sure all of you, whatever organisations you work for, will have value statements, and I'm sure nobody has, we live out of fear, we make our decisions about, out of what's going to be the least harmful. Those are not positive value statements. So I try in conversations to help people to not make their own personal decisions out of that. I might just specifically talk to Catherine's question about discussions about what the vaccine brand, because I think that's something that is just pertinent at the moment, but I don't think that'll be there forever. So I'll just very briefly address that. It has been a nightmare as a GP. We have had 12 vaccine schedule changes in 3 months. And you can imagine trying to adapt your policies every couple of weeks as to what you do. It's just been horrible. And there've been times when I've been seeing patients for the day, and patients have come in and said, hey, there was an announcement at lunchtime, and do you know what Atagi's recommending now? And suddenly my afternoon session has to be re-looked at, and we're phoning patients and navigating the new way forward. I feel like I'm in 1984. What I'm saying today is completely the opposite of what I had to say yesterday. So that's been a nightmare. So I guess the thing is, as far as choosing vaccines go, I think that we probably will have that option down the track. And when that comes to that, I know that Sydney Uni is working on a decision-making process, shared decision-making kind of, what do we call it, a decision aid. So that'll make it a lot easier, because we can then actually have in front of us the pros and cons of each vaccine and kind of work through it in that way. That, though, is addressing their head. And if people have questions about their head, that will be helpful. In my experience, most of the time it's more a question about their emotions. And one thing I've learned, both as a married woman and as a doctor, is you cannot address a question that's an emotional question with a fact. Never address an emotion with a fact. It's often the other way. It's often, like the woman will come to the man. I'm being very stereotypical here. Okay, I'm talking about my relationship. Your relationship might not be like that. So, I might go to my husband and say, I'm feeling really, that you're not giving me as much attention as I would like at the moment. And if he pulls out and goes, no, well, actually, let's have a look at the last week. This is the time that I spent with you, X, Y, Z. That is not the right answer, right? Never answer an emotion with a fact. So what he needs to do is answer the emotion with the emotion and say, sweetheart, I really love you. I really care about you. I'm sorry that you're feeling that way. And it's the same when we're dialoguing with our clients and with our patients. If somebody's coming in with an emotional response, we need to try to address that emotion and acknowledge that emotion. And not to say that we don't then bring facts into it, but the first thing to do is making sure that we're getting behind that emotion. Empathy.
Can I just ask something there? So what's the equivalent of so we have a health clinic here, so we do have a lot of, this is on a slightly different tack at the ASRC, but we have a lot of members, people seeking asylum that come in for vaccination and with serious health concerns and with very, very serious and understandable distrust of institutional power. The government that is trying, it's a difficult position for us. The very government that's screwing them over, we're asking them to trust that government with a vaccination program, right? So it's complicated. What's the equivalent of your husband saying to you, sweetheart, I love you? What's the equivalent of that when the patient says, look, I'm really unsure about this. I don't trust the big pharma or the government, or, what are some of the things that you say?
Look, so great question. You have been approached because they trust you. And so what you can do is, rather than saying, well, I trust the government or I trust big pharma, because you might not, and to be honest, I don't 100%. But what you can do is you can say, look, I have chosen to trust this. And basically what you're doing is you're asking them to surrogate their relationship with you with their decision. So that is where some people can get very uncomfortable with that. But because we are influential, if people are coming to us and asking us those questions, that we are influential. And that's where we need to actually become comfortable with the fact that we are in that position, and making sure that when we do have those conversations with people, we're not doing it because we need to feel important or we need to feel that people care about what we think. We need to be, and if we need to deal with that, that kind of God complex, that's important to deal with. But at the end of the day, our disposition and our heart and the way that we interact needs to be for what's best for them. And if you honestly believe what's best for them is, well, let's keep it very simple. If what's best for them is to have the vaccine, then it's not kind, it's not loving, it's not thoughtful to turn around and say, well, actually, it doesn't matter what I think. You make your own decision. That's abandoning people. So if we genuinely are interested in what's best for the people that we work for and work with, then we are going to be aware of our influence 100%. Don't use it to manipulate people, but to then actually, I guess, use that force for good and to, again, we're not going to force people, but we're going to say, I trust this vaccine. Now, I have reasons to trust this vaccine, and I'm happy to go through those reasons with you, but what they will hear more than all of the numbers that you can give them, they will actually hear your heart. Your heart is for them. So you're answering an emotion with an emotion. You care about them. You care about what's best for them. You care about what's best for their family and their community. And based on that, you actually do trust the decision to have the vaccine. No, does that kind of answer your question?
Well, we are going to have to wrap up because I knew this was going to be a fantastic conversation. And of course, there are, more questions that we could ask you, Tash, but the time is ticking and we have to let people go. So I wanted to just wrap up, I suppose, what I heard today. I heard about you talking about listening to people. So really listening to people's fears or, the decisions that they're struggling with. So really thinking about how we listen to people and how we enable people to talk about the decisions they're making. You talked about empathy and really trying to contextualize the conversation or the information sources. I think you talked about patience and, again, not coercing people into making quick decisions when they're not ready. So finding out what information people need to be able to make their comfortable decision. And then you talked a lot about thoughtful answers, not, again, rushing off to sources that you haven't checked out, but really making sure that you are providing thoughtful answers to people that empowers them and encourages them to make a decision for themselves. And I just think, those are really great practical things that we can all think about, whether it's us as individuals or us as organisations. I think those are really good principles. So thank you so much, Tash. We love talking to you. You have been a very honest and authentic voice in this whole thing for a while now, and we encourage you to keep talking to us through the conversation or radio or, whichever way you can. We really do need your voice amongst all of this. So thank you so much. I am just going to finish today by saying that next month we have a great person coming along called Dr Natasha Yates. She's going to talk to us about resilience and how we're faring with our mental health. We're 6 months in next month, and that means we're halfway through the year. So I'd enjoy if you could all join me again next month for Tea and Buns. And again, thank you for coming along today and sharing in the conversation. Thank you, Tash. All right.
Pleasure.
Thanks for the link. That's great.
Yeah, I just popped a link in that I found very helpful. This is a government link, and it actually answers a whole lot of questions that I didn't even know people were asking about COVID vaccine. Some of them really bizarre, but I find that helpful. And I think we've already mentioned the WHO, CDC, some other reliable.
We'll pop some links up on the blog as well. That'd be great. Yeah.
Great.
Okay. All right.
Thanks, Ruth. Thanks, everyone.
Thank you.
Thanks for joining us. Okay.
Bye, everyone. Bye.